I'm Alexandra Jones. I'm the editor of The Ophthalmologist, and I'm here with Dr. Manuel Domingues from Hospital da Luz in Porto, Portugal, to talk about Rayner's new RayOne EMV IOL. Dr. Domingues, could you tell me a bit about yourself and the type of patients you see at your cataract service?
Well, I'm head of ophthalmology at a private hospital in Porto, Portugal, and I see a mixture of cataract and refractive patients. And I'm a high-volume surgeon performing around 2,000 surgeries, cataract procedures every year. And I often present at FACOELG, ESCRS, ASCRS, and National Congress.
Thank you for the introduction. Let's get started then. What is your patient selection criteria for monovision?
Typically, patients who are not expected to tolerate dysphotopsia, as well as patients with affordability concerns about trifocal lenses.
Thank you. And before you started using the RayOne EMV IOL, what was your experience with monovision?
Well, I used to perform monovision just in previous anisotropic patients, and in some patients with no need for driving, and they don't need to read, and some older people. So actually, it was not the first choice for my procedures. That's it.
That's interesting. So as an early implanter of this lens, could you tell me about your impressions of it and its suitability for monovision?
Well, the central region of the optic induces positive spherical aberration that extends depth of focus. Results from optical bench studies show that the depth of focus can be as much as 2.25 if you use 1 diopter offset. This means that the patient benefits from superior intermediate vision whilst maintaining excellent distant vision when compared with standard monofocals. The fact that the aberration is positive rather than negative increases the overlap between the dominant and non-dominant eye for a smoother transition between distance and intermediate vision, maintaining stereo acuity and reducing asthenopia. RayOne EMV is a refractive lens and therefore has a significantly lower incidence of dysphotopsia when compared with diffractive multifocal and extend depth of focus intraocular lenses.
And could you share what monovision offset you have been using with this lens?
I've been targeting -1 to -1.25 in the non-dominant eye. I've been targeting plano to -0.5 diopters in the dominant eye. The patients start targeted with -0.5 diopters in the dominant eye. They are achieving 20/20 for distance vision with a seamless transition between their eyes.
Thank you. And could you tell us about early patient outcomes you've observed with the RayOne EMV IOL?
I've so far implanted RayOne EMV in 60 eyes of 30 patients. Bilateral incorrect distance visual acuity and bilateral incorrect intermediate visual acuity are 6.6, so spectacle free. Patients are reading N8 at 100 centimeters and N4 at 40 centimeters. No reported dysphotopsia and very few reported some asthenopia in the first month. Patient satisfaction has been 100%.
That's great to hear. And what are your thoughts on the RayOne preloaded system?
I'm used to it for 4 years ago. It's very quick and easy for my clinic team to prepare. There are only 2 steps: insert the OVD and close the wings. I can implant RayOne EMV through a 2.0 incision, and the lens and the injector behave predictably and are very surgeon-friendly. Once in the capsular bag, the lens centers very, very well.
So based on your experiences so far, Dr. Domingues, are you planning to adopt RayOne EMV as a long-term option for your patients?
Yes, I think it's important for surgeons to have a variety of lens options for their patients, depending on their lifestyle and post-surgery visual expectations. If I believe monovisions is the right option for a patient, then RayOne EMV is definitely my preferred solution because the extended depth of vision it creates whilst reducing asthenopia compared with standard monofocal IOLs. And if targeting metropia in both eyes, then RayOne EMV can provide up to 1.25 diopters of extended depth of vision.
And finally, what do you feel is the unique opportunity with this innovation?
Well, RayOne EMV, it's a game changer in presbyopia treatment with possible use in patients contraindicated for multifocal IOLs. For the large number of surgeons around the world performing monovision, of course, they should certainly be considering RayOne EMV, which increases their patients' depth of focus and consequently satisfaction with surgery.
Dr. Domingues, thanks a lot for your great insights.
Thank you, Alexander. The pleasure was mine. Thank you.